IC, which is managing the most dreaded complication, and that is ocular hypotony. And I have the privilege of inviting my co-instructors on the stage, Dr. Divyansh Mishra, Dr. Unni Krishnan, Dr. Sangeet Mittal, I think he's still to come, and Dr. Vishali Gupta, and Dr. Mahesh Shanmugam. So I think without much ado, I'll start with my keynote address, which is, I'll start with that, though I think it's at the end. So I think, what do you people suggest? Take it at the end? Okay. So as we all know that ocular hypotony is something very difficult to deal with. We all are quite geared up to deal with high pressures, but ocular hypotony is something which is very harmful to the eyes. And this entire IC is going to be dealing with various causes and how to be managing ocular hypotony. So we have our first speaker, Dr. Divyansh Mishra. And Dr. Divyansh Mishra is a senior vitreoretina consultant from Shankaraya Hospital, Bangalore. And he would be speaking to us on definition and what are the various risk factors for ocular hypotony.
AV team, presentation. Divyansh. I uploaded downstairs. Yeah. So good morning all. Thank you Manisha madam for the opportunity. So the topic for presentation is definition and risk factors of ocular hypotony. So basics about it. So what is exactly an ocular hypotony, where the intraocular pressure is either less than 5 mm of Hg, which has to be recorded at least 3 times, or if it is 6.5 mm of Hg, because there are controversies whether 5 or 6.5. So both the studies suggest that 5 and 6.5, so we can take either 5 or 6.5 as an average. It can be either clinical or subclinical or acute and chronic depending upon the issues associated with it. The actual frequency or the incidence of hypotony overall is not known, but associated with surgery like glaucoma with MMC and all is 7%. With chronic inflammation like juvenile uveitis is 15%, and ocular trauma is around 7%. So this is a usual flow of aqueous from the ciliary body to the uvea or either trabecular meshwork. So either it can be because of excessive drainage of aqueous, which is outside the eye, or it can be reduced aqueous production itself. And then once the volume is decreased because the pressure is so low, the axial length of the eyeball decreases, and because of that there is inward folding of the sclera. And because of that, the choroid and retina also gets folded up, and that's how you see the folds over the retina and the choroid on the posterior pole. So the etiology depends upon whether it's an extra fluid which is lost either because of the trauma, surgeries, like if it's a leaky wound, either in via surgery or itself in a cataract surgery, or reduction in aqueous procedures, aqueous production itself, either by the chronic inflammation or topical or systemic medications, or PVR, which is pulling onto the ciliary body and causing hypotony and associated ciliary atrophy. So the ocular hypotony table is divided like either decreased aqueous production or increased aqueous outflow, and then a reversed osmotic gradient. So in this, the ciliary body hypoperfusion, as we were talking about the OIS or the ciliary body detachment, which occurs because of the PVR or chronic uveitis or capsular contraction, uveitis itself, or iatrogenic like aqueous suppressing medications if we are giving, or cyclodestructive procedures what we do, or antersegment ischemia secondary to the surgery like a strabismus surgery. If the globe is intact and we are seeing that it's increased outflow, then it can be because of the cyclodialysis cleft from where the aqueous is drained out of the choroid and then it doesn't remain in the eye. Either it can be traumatic or iatrogenic at the time of surgeries. A rheumatogenic retinal detachment or congenital syndromes like myotonic dystrophy and physiological like in pregnancy we may have it. Or if it's a compromised globe where the eye is completely collapsing, either it can be traumatic, it can be iatrogenic because of the surgeries, whatever we do, or it can be congenital weakness like in coloboma or Marfan syndrome. And reverse osmotic gradient, which occurs in severe dehydration, uremia, ketoacidosis, hyperosmolar medications, and exercises. Systemic medications which can causes like Diamox, which we usually give them for decreasing the pressures, and antihypertensive medications are also known to have little hypotony associated with it or decrease in intraocular pressure. and nitrates, antivirals like cidofovir, and hyperosmotic agents like mannitol. Systemic causes, as we were discussing, pregnancy, dehydration, uremia, diabetic coma, and Marfan syndrome, and other hereditary like myotonic dystrophy. So, what exactly occurs in that? You see the hypotony maculopathy, which is usually associated, if it is long-standing, can be associated with hypotonic keratopathy also. And because of the hyperopic shift, as you were discussing, because the intraocular pressure decreases and the axial length decreases, there can be even swelling of the optic nerve head also. So it depends upon the etiology what we are dealing with. Either it can be trauma, uveitis, or an RRD. It can be associated with systemic issues, as we were discussing, from pregnancy, uremia to other systemic associations. And yes, most importantly, ocular ischemic syndrome also is one of the cause for it. As you were discussing, if there is an actual trauma, all the aqueous is drained out of the eye, and that's where you would see the hypotony. And it can be because of surgery, as you are seeing. Sometimes it can be because of the ciliary body perfusion, which is lesser, or ciliary atrophy, which can be associated with either RRD or a choroidal detachment also. Chronic sequels of hypotony, we may see a little corneal decompensations, and sometimes there can be BSK changes over the cornea. So the fundus changes, as we were seeing, with the choroidal folds, which we can see on the periphery, and there can be retinal or the macular folds, and there can be optic disc edema. And if the intraocular pressure is very low, you may see a very significant gross elevation of the optic disc. If you do an intersegment OCT, you may see a cyclodialysis cleft. And if you do a gonioscopy, this is a direct gonioscopy where you may see detachment or a cyclodialysis cleft kind of an appearance. And OCT would give you an understanding of choroidal folds, retinal folds, and even disc edemas. P-scan helps you to identify the cause, like in this case, vitreous inflammation. Sometimes the inflammation can also have CDs. There can be separation. Sometimes there is so low that it can land up into choroidal detachment with hemorrhages. And there can be a combination of both, and there can be associated retinal detachment. So the take-home message is the prognosis and the outcome of the ocular hypotony depends on the cause, like either it is traumatic or probably surgery associated. And most importantly, if you are finding a specific cause, better is to treat it like a retinal detachment or an ocular trauma, which it requires surgery. An urgent consultation with a multidisciplinary and interprofessional team needs to be taken care of, where either a glaucoma colleague or a cornea colleague or the retina itself. So thank you, and probably we may break for discussion right now, man.
I think we'll take up some questions after two talks.
Sure, thank you.
So thank you, Divyansh. And after you've highlighted all the possible causes of ocular hypotony, I now invite Dr. Unni Krishnan Nair, who's the director of Chaitanya Eye Hospital, Trivandrum. And he would be speaking on prevention and management of post-surgical hypotony, and probably we can take up some questions after that.
Okay, thank you for the intro, and there's going to be a little bit of overlap between the last talk, but this is, as I said, there is a statistical definition of hypertony, and there's a clinical definition which Dr. Divyansh has mentioned. And basically, to divide everything simplified, there are two methodologies. One is because of an aqueous outflow, that is external fistulation, which may be to the exterior or the subconjunctival space, where you can have corneal lacerations, scleral lacerations, or a filtering surgery, which is the external fistulation, or internal fistulation like cyclodialysis and the works. But there is also one more circuit that is called the posterior circuit, internal fistulation, where when you have an exposed RP and exposed choroid, there is an increase in the uveoscleral outflow. So there is no necessary direct communication to the outside, but there is more absorption by the RP pump or an osmotic gradient through an exposed choroid. So that is called the posterior circuit, or the posterior removal of aqueous. A ciliary body insufficiency, as Dr. Divyansh has mentioned, by extensive cyclodestruction, and inflammation as a major cause of reduced production of aqueous. So these could be the major pathophysiological causes, but it can be broken down to two, that is decreased inflow because of ciliary body damage, and increased outflow because of fistulas, holes, or the posterior circuit, as we mentioned. So while looking at hypotony, one is a definition of low pressure, the functional changes, it may be symptomatic or asymptomatic, and the structural changes, which is important to realize in this concept. There is a transient phase of hypotony, which, if not treated aggressively at that stage, it goes into chronicity and probably it becomes more and more difficult to treat. So I'm just going to skip this. So evaluating any hypotony from a management perspective would be look at the circumstance, understand the mechanism, look at the prevention at that point, and the treatment. So some of the scenarios we face hypotony, post-surgical, post-operative are these scenarios. And let's look at cataract side. The circumstance could be a leaky corneal wound, an occult cyclodialysis, or a choroidal detachment. The mechanism would be, as we said, if it's an occult wound or a thing, it would be an external fistulation. If it's a cyclodialysis, it would be an internal fistulation. And if there's a choroidal detachment, it is the mechanism, as I said, the posterior circuit of removal. The prevention is after a cataract surgery, when you see a shallow bleb forming or a hypotony, to inspect the wound properly. Avoid a lot of AC maneuvers while doing violent or inflation or all those maneuvers while doing cataract surgery, and prevent a sudden intraoperative hypotony, which can create the choroidal detachment and start the cycle of hypotony. So after cataract surgery, what would be the treatment? That is, inspect the wound. If there's a wound, leak, an AC reformation, a compression bandage, and observation would be a conservative way. You can wait for a few days to see if the wound closes up or becomes competent, or an inverted bleb that is created can be collapsed. There is a controversial way of reducing flow through an occult fistula, that is to reduce the IOP even further, and then the flow reduces, it closes, and then it builds up after that. But there is a small danger regarding that of worsening the hypotony. Cyclodialysis can be diagnosed using a UBM and anterior segment OCT, and traditional treatments are diathermy, laser, and cryo. Direct suturing and AC reformation can be done. Choroidal detachments, usually in the transient phase, they can resolve spontaneously, or a drainage with AC formation may be required. So let's look at just another point, is that hypotony can also cause cataract. So the hypotony, there are hypotony associated, nearly 33% of patients with hypotony develop cataract in a very short period of time. So after filtering surgery, what is the tendency of hypotony? One is you have your aim target IOP and you overshoot it by your surgery, or the hypotony that's induced by antifibrosis agents or the incidence after aqueous shunts. So in filtering surgery, a sudden drop of IOP and overshooting could be one of the things that start the cycle of hypotony. And we know that in the previous full thickness surgeries, you had extremely high rates of shallow ACs and choroidal detachments, which are less over time. The antifibrotic agents have, by nature, they are supposed to reduce the fibrosis, reduce the scarring, and increase the drainage. But by nature of their chemical nature, there are some effects like inducing a ciliary body inflammation, which could contribute to more reduction of the IOP than is expected by their antifibrotic effect. Aqueous shunts cause transient hypotony. And there are many mechanisms, including tube ligation, occluding the stent, doing it as a two-step procedure. But one thing that has to be noticed is that when you do an aqueous shunt in an aphakic patient or a vitrectomized patient, the chances of developing a transient or hypotonia are higher. So the prevention could be to do a really good gas fill if it's a vitrectomized patient, to reduce the incidence of post-operative hypotony. And just for your information, double shunts cause more hypotony. So if you expect a patient that is going to go, you can use a single shunt device, single plate device, and concurrent use of mitomycin could also be a feature that has to be avoided. So other procedures that can produce are cyclodialysis and cyclodestructions. And I just want to touch about the post-operative inflammation. See, the post-operation, the inflammation component is there in every surgery, and sometimes an overwhelming inflammation produces a transient hypotony. So this is the stage where it has to be dealt with, and the chronicity should be avoided. And After vitrectomy surgery, as Dr. Divyansh was mentioning, there is a convexity of the globe, tension of the globe, which is altered sometimes in vitrectomy surgery, and this was previously called the hypotony syndrome or the iris root retraction syndrome, and could be associated with anterior PVR changes. So the role of vitreous generally is thought to be a hyaluronic acid plug, which plugs in a patient who is aphakic if the possibility of the excessive outflow is reduced by the vitreous, the hyaluronic acid in the vitreous, and that is why a vitrectomized eye could be more prone to hypotony. So these are some of the, as I said, the large breaks, having large retinal detachments, the posterior circuit coming into action. The presence of rubeosis is a tendency because of the drop to form hypotony. Chronic inflammation produces membranes, and all these, I think this is going to be dealt with later. So I just want to put in a small algorithm first. If it is transient, look for the immediate post-operative causes, wound leak, cyclodialysis, and you can observe. But the main point is to prevent the transient from becoming chronic. And when it becomes chronic, there could be an element of chronic inflammation, ciliary body membranes, and increased outflow through the ciliary body and the posterior circuit. And then definitive treatment like managing the inflammation, surgery could be assessed. So I'm just showing a small couple of videos here. Here, what is shown is in this video is a bleb in which a limiting suture is being kind of placed all around it to limit the filtration area. This is a delimiting suture around the bleb to reduce the area of the bleb expansion over here. You can see the suture going around and the changes. So this is, the next one is a very, this is just to reduce the filtration. It's a autologous blood injection to reduce the, delimit the bleb so that the fibrosis happens on the side and reduce filtration. Here you can see the compression sutures on the bleb, which is used to reduce filtration. And this is something that I have used. It's not officially recommended, but sometimes all of us know that difluprednate causes a raised IOP. So sometimes in cases of transient hypotony, difluprednate can cause an increase in the IOP. But it's a double-edged sword to use it sometimes. And this is something that I've done in a few patients, which I'd like to highlight. It's the encirclage technique. When you have an unexplained hypotony, as we had in this particular patient, you can just do, an encirclage procedure. The point is that it reduces the UV, it kind of compresses the external, the uvascular outflow sometimes, and if there is occult flow to the posterior circuits reduced. So this is a simple buccal procedure. But I just wanted to show you the results of what this is. A patient who had this is a silicone oil filled eye with hypotony. You can see the disc edema, the folds happening, and we just put a buccal which was slightly more anterior and a bit high. And over time, you can see that the venous congestion has come down, the disc edema has come down. And this is a patient who this is the last one, this is the beginning and the end picture, while just an encirclage has reduced and treated the hypotony to such a level that the disc edema has come down, the vascular dilatation has come down, and the macula, that's an artifact in the center, but the macula looks okay. So to summarize, the circumstances of hypotony could be varied. The mechanisms are either an inflow reduce or an outflow excess. The prevention is proper surgical technique, and the treatment in most cases is to treat early. The concept is to treat early when it is transient rather than it getting fixed and becoming chronic. Thank you.
Thank you, Dr. Oni, for elucidating all those various causes of hypotony. Are there any questions from the audience? So I have one question for you, that if you are dealing with a patient with retinal detachment with choroidal detachment, apparently there would be an underfill of the silicone oil if you decide to operate immediately. How do you post-operatively follow up this patient, and when do you plan to go back and do a little top-up of oil?
Is it from a perspective of detachment repair or a perspective of hypotony?
Hypotony.
So generally, as I would say, I don't think the oil is going to contribute. The underfill of oil is not going to contribute to the hypotony. It is basically the reattachment of the choroid and the retina that is going to be more important. So even if it is an underfill, if the oil is has done its job in reattaching the retina, having an endotamponoid at that point of time. It may go through a phase of transient hypertony, but the main point is that if you have reattached the retina and the choroidal settled down, the underfill is not going to be contributory towards the hypertony.
Hypotony. Any comment from you, sir?
I would agree with Unni, and usually retinal detachment, choroidal detachment, you drain the choroidal detachment, and like most of the time, nearly about 90% of the choroidal detachment is drained before you are able to fill the tamponade. So, and it's usually a fresh RD. You may not even be using oil, so you may be using gas.
Right.
So I don't think it's too much of a concern as far as hypotony is concerned.
And would you opt? Yeah, please go ahead.
In now I would titrate this. This ended up a little bit high because of two reasons. Because you're operating on a hypertonous eye, one. But the only modification I do is that for me the encirclage would be more closer to the muscle ring, more anterior, because the concept is not an aura creation or a tampon or an buckling effect. The idea is to break a circulation from occult cyclodialysis or from generally a uvascular outflow. Yeah, it is. I have to be honest, this is a patient who was a uveitic patient, both eyes operated, both eyes with silicone oil inside, both eyes with hypotony. The left eye worked very, very well. The right eye, the minute I put it inside, it pushed all the oil into the anterior chamber. Then I had to struggle to manage that. And the right eye is always a little bit worse than the left eye. The pressures have just come to about 6 or 7, 6, 7, 8, but the disc edema and the macular folds have ironed out. So, yeah.
So, I just wanted to ask you, like, very typically we get these children with JIA, and they are the ones who have actually undergone an IOL implantation with a lot of chronic post-op inflammation. And despite having explanted the IOLs, they continue to have very, very bad chronic hypotony. Even if you put in silicone oil, then they start developing a BSK. In those situations, any role of an oil retention sutures?
Oil retention sutures generally are required when you've taken off the iris also. When it's a totally aphakic patient is when you put crisscross oil retention sutures. When there is some amount of iris, it usually keeps the, even if it's aphakic, it keeps the oil behind. But in these patients, again, it is the pathology that is happening at the ciliary body level that is more important than the detachments, whether it is inflammation or whether it is
but
epithelial
despite
membranes.
the iris being there, because of the chronic hypotony, you tend to have the oil all the time coming into the AC, and probably that's contributing to the BSK.
Yeah, so what I have seen is that placing an IOL is a key feature over there in some methodology. The second is using oil retention sutures are okay, but again you are passing your crisscross sutures very close to a damaged pars plana and very damaged areas.
Can I add something? In such a situation, if the iris is still okay, it's not retracted, then I would probably think of doing a pupilloplasty. Rather than doing an oil retention suture, you can probably make the pupil smaller so that the oil doesn't come into the antechamber. Why oil is coming into the antechamber in this patient is because the ciliary body is not secreting. So you would probably make the pupil smaller so the oil doesn't come into the antechamber, despite which it may come. So you'd probably use a 5000 centistoke oil and make the pupil smaller.
Dr. Divyansh, any role of posterior subtenon tricot?
So yes, that's the last resort which we try, but whether it actually works or not, the answer is very difficult to suggest, because what we think that the steroid is causing a trabecular meshwork scarring, and that's where the outflow is getting occluded, and whatever the inflow or means whatever this aqueous has been produced, it is expected that it would stay in the eye. But it all depends whether the ciliary body is functioning or not, and then is when the whole answer of whether the means that's the final resort. Because there is one more drops I forgot, not the difluprednate, there is I'm
There
just
was
missing
something
the
which was mentioned about 3-4 years back. There was a literature on it, and we tried getting it. I'm also
I
unable
would
to
source
get
and
it.
let you know. But there is one of the drops which has
Which was
been
not available in India. Which
India,
was
yeah.
there was a trial where it did increase the intraocular pressure by about 3. It's not available in India. That's right. What was the name again, man?
I'm just
Okay, fine. Sure, that's right. Yeah, it increased by about 3 to 4 millimeters, if I remember right. Yes. And
So-
like despite what Divyan said, like it's not as though like subtenon steroid is the last resort. The fact that we don't get to do something, we want to do something, so we keep injecting subtenon steroid quite often. Whether it works or not, we don't know.
So I'll move on to the next talk, and that is by me. I'll be dealing with cyclodialysis cleft. No, the other talk. So good morning, everyone. And I would be basically dealing how to go about managing a cyclodialysis cleft. So cyclodialysis cleft is basically the separation of the ciliary body from the scleral spur, secondary to most commonly a blunt trauma. But also it could occur as a complication of a surgical intervention such as a glaucoma surgery, trabeculectomy, which is very commonly performed. Even a simple cataract surgery can cause a cleft, and secondary IOL implantations, and so many other described anterior segment procedures. The extent of the cleft may vary, causing a flow of the aqueous directly to the suprachoroidal space and subsequently causing a persistent hypotony. Now, many small clefts actually do not need an intervention and they happen to close spontaneously. How do you really go about diagnosing a cleft is you can perform a gonioscopy, which is going to be very relevant when the hypotony is not very severe. But if the globe is deformed, you can actually inject a viscoelastic in the anterior chamber, reform the globe, and then perform the gonioscopy. So, on gonioscopy, there will be an abnormal region posterior to the scleral spur, displacing the iris root and ciliary body posteriorly. Now, there can be a variable appearance of this cleft. It could appear like a white band, a gray, or a black band, as shown in the photo over here. And as I mentioned, you have to reform the globe because gonioscopy may not be possible if your globe is totally deformed. You can also take the help of ultrasound biomicroscopy, and it can beautifully show you the cleft, and also an anterior segment OCT. Now, as far as small clefts are concerned, you can even get away either by just observing them and they can close spontaneously, or do a medical management in the form of cycloplegic drugs, which again are very useful, or sometimes even topical steroids. Now, there is a controversial belief of using topical steroids because they actually are going to inhibit the inflammation and they are going to prevent the closure of the cleft. So some believe that it's best avoided, that you do not use topical steroids, while some say that it is good to control the inflammation. The other way of managing the clefts can be by using laser photocoagulation. Local inflammation is going to happen secondary to laser photocoagulation, and it is going to help to seal the cleft by causing adhesion between the choroid and the sclera. As far as the surgical intervention is concerned, the best time of repairing a cyclodialysis cleft is said to be within the 3 months of its occurrence, and you can have an extraocular approach or an intraocular approach. As far as the extraocular approach is concerned, the best is to do a cryopexy, which is done 3 mm behind the limbus to the area of the cleft, which is confirmed intra-op by doing an intra-op gonioscopy. And this is found to be most useful for smaller clefts, which are varying between 3 to 4 clock hours. You can use a double or a triple freeze thaw technique, and this is going to be useful for closing these clefts. As far as the intraocular approach is concerned, you can again do a direct intraocular cycloplexy to the refractory clefts which are not responding to a transconjunctival cryopexy. You can also suture the ciliary body to the underlying sclera with 8O or 9O nylon mattress running sutures. Now, the various techniques which have been described in literature for the management of these small 3 to 4 clock hour cyclodialysis clefts are several. Even an encircling band, as was mentioned by Dr. Unni, is going to be useful for the closure of the smaller clefts. Now, however, there is a paucity of techniques described in literature for the management of larger cyclodialysis clefts, which are going to be more than 6 clock hours. So this is a technique which I have learned from Dr. Divyansh, and he is the one who actually taught me, and now I have done it in several cases. Can I have the voice, please? And vision of 624 N24 and a pressure of 2 millimeters of mercury. There was subluxated lens and hypotony maculopathy. There was 360-degree cyclodialysis cleft.
Here's how a sewing machine works. There's a threaded needle above the fabric. When it pierces the fabric, a rotating shuttle hook below catches the thread.
We present the sewing machine technique to repair a cyclodialysis cleft. Lensectomy and vitrectomy was done, followed by intraop-gonioscopy to confirm the extent of the cleft. A scleral flap was made and 10-0 proline suture was threaded into a 26-gauge needle. And the needle was cut off. The needle with proline suture was passed through the cleft, and a loop was taken out, which was kept in place with the help of a 30-gauge needle. This was repeated multiple times, and multiple loops were taken out, which were kept in place with the help of the 30-gauge needle. The 30-gauge needle was extended to keep all the loops in place, and the suture was finally pulled out. And the tenoproline suture was then passed through all the loops. The 30-gauge needle was removed and the suture was tightened. This was repeated on the other side as well. The follow-up at 12 weeks showed a vision of 6/9/N6 with an intraocular pressure of 18 millimeters of mercury. So finally, at about 12 months, the patient had, at 6 months, the patient had undergone a secondary IOL implantation. And finally, the patient had recovered a vision of 6/9/N6 and was maintaining a good intraocular pressure of 18 millimeters of mercury. The technique may appear very complicated, but it is not so. And for these larger cyclodialysis clefts, it works beautifully. Till now, we have done around 5 patients who have undergone a similar, the sewing machine technique. And they've all done very well. Many of them have already undergone a secondary IOL implantation. So in these 5 patients, all of them had a large cyclodialysis cleft, 4 had blunt trauma, and 1 was status post-trap. The average IOP at presentation was around 3.4. They all had at least 6 months follow-up, and the average post-op IOP was maintained at around 10. And there were absolutely no post-operative complications that we encountered in this case series. So therefore, to conclude, cyclodialysis clefts are most common after a blunt trauma or surgical trauma and may cause a persistent hypotony. They are best managed within 3 months of their occurrence. And smaller clefts, you can either decide to observe, start the patient on medical management with cycloplegics and steroids, and subsequently you can also try a laser photocoagulation or a cryopexy. However, larger cyclodialysis clefts where you really don't have any other option, the sewing machine technique is worth a try, because we've already had the experience of doing it in 5 cases, and Dr. Divyansh has also tried it in a number of cases, and the patients are doing pretty well without any post-surgical complication. So these are a few of the references which were relevant to this topic, and thank you for your patient listening.
Thank you. And Dr. Manisha deserves a better introduction than that. She is the secretary of the Vitreoretinal Society of India and the head of the retinal services at Shroff Charity. And she actually deserves, for this wonderful IC, a big round of applause for her for this wonderful IC.
Thank you so much.
I'd like to invite Dr. Sangeet, who is the retinal surgeon at the Tindai Hospital, Jalandhar. He has been honored by AIOS multiple times for his innovative videos and techniques, and he will be talking to us about managing choroidal detachments.
Mouse is not coming. Somebody from here? Somebody from the team? The mouse is not coming on the screen. Mouse? Yeah. I think वो आ गया नीचे.
Can somebody? It's not seen here in the laptop. Mouse is not working. भैया ओ पैड में एक working होता है.
Good morning, everyone. So I'll be discussing with you how to manage choroidal detachments, and so choroidal detachment, as we all know, is a separation of choroid from sclera by accumulation of fluid, blood, or air. So it happens when a potential space is converted into a true space. So there could be a serious type of choroidal detachment where the low IOP promotes transitation of fluid out from choroidal vasculature. Could happen in post-surgical hypotony, post-traumatic, or secondary to inflammation. You can have a hemorrhagic choroidal detachment due to rupture of choroidal vessels, which can happen spontaneously or during surgery or during trauma. Or you can have an uveal effusion syndrome, which can be associated with choroidal detachments. So this is a various differential diagnosis, various causes which leads to choroidal detachments. This includes scleropathies, the inflammatory causes, the hydrodynamic causes, and the neoplastic causes. So how to differentiate between a serous and a hemorrhagic choroidal detachment? I think the B-scan ultrasound is the best tool. In B-scan, in serous choroidal detachment, you'll have a smooth dome-shaped elevations, which are free from the optic nerve. They are not attached to the optic nerve. So and there are no after movements and very low internal reflectivity. So this internal reflectivity is the thing which differentiates the serous choroidal detachment from hemorrhagic choroidal detachments, which appear like this. So again, smooth dome shaped, free optic nerve, no after movements, and high internal reflectivity. So I think a B-scan becomes important when you have a choroidal patient with choroidal detachment coming, to differentiate between a serous and a hemorrhagic choroidal detachment. So how to manage serous choroidal detachments? Most commonly is a conservative approach, because most of them often spontaneously they come down. You can give oral as well as topical corticosteroids and topical cycloplegics. If there are any wound leaks, you can apply a pressure patching or a bandage, contact lens, or glue. Basically, you have to build up the pressure. And if the patient is in ciliary shock post surgical, you have to give oral fluids just to relieve the ciliary shock. Then if nothing of this is working, you go ahead with the surgical approach, in which is if it is a non-resolving or recurrent choroidal detachments, or you are having a persistently flat AC, which may lead to synechiae formation, or you have a kissing choroidals which may not heal spontaneously, and intraoperative during VR surgery, if you find there is choroidal detachment, you have to manage them intraoperatively. And similarly for hemorrhagic choroidal detachments, again, the conservative approach includes the antibiotics, corticosteroids, cycloplegics, anti-glaucoma drugs, and oral fluids. And in surgical, again, it's an uncontrolled glaucoma. If it is an uncontrolled glaucoma, if there are kissing choroidals, or if there's a persistent vitreous hemorrhage or retinal detachment, you go ahead with the surgery. So now I'll show some videos on how to manage this. So first thing is, when you are operating, you're doing a vitreous surgery, you have to be sure that your cannula is in the vitreous cavities. Sorry, the video is not playing. No, the first one was not playing. So this is what is called an endoilluminator reflex test. I think it gets stuck over here. Yeah. So you just what you do is you just take your endolite and you insert it in inside the cannula which you have just placed, and you will get this reddish brown reflex instead of a very good white reflex. So this is so you know that there is choroidals and your cannula is not in the true vitreous cavity. And you see this is the white reflex you should get if your cannula is inside the vitreous cavity. So you can compare it again. You see that this is the reddish brown reflex and this is the white reflex you generally get. So this again, the third sclerotomy is made and you again see that you are getting a white reflex. So your cannula is in the space. So don't use the cannula which you have made for infusion. You put your infusion in one of the other cannulas and you start your vitrectomy, and now you confirm whether your cannula was in the right space or not. And you see your cannula was not in the right space. It was covered with choroid. So you just cut back the choroid, and once the cannula comes into the vitreous cavity, just clear off the vitreous and other tissue which is over there so that the cannula stays in place. And now you see the reflex again. It is a white reflex. So this is an important test which you can do to evaluate whether your cannula is inside. So this is how you do the 26 gauge needle to manage intraoperative this choroidal detachments. So once you are completed with the vitrectomy, you see there is a choroidal detachment superiorly, and now you just take a 26 gauge needle and just go into the suprachoroidal space. The fluid starts draining because there is an infusion, and with the passive outcome of this suprachoroidal fluid, now you see the choroidals have settled. So you can use a simple 26 gauge needle to drain this space. Now this is a video which was given to me by Dr. Manisha, and what she has used is the use of a non-valved cannula to drain out this suprachoroidal fluid. So you see this fluid comes through this suprachoroidal, and you can manipulate the cannula to have a proper drainage outside. So now you see the choroid which was detached has now, the fluid has gone and it's relatively attached. So I generally use a technique what I call a controlled cannula drainage. I use a 26 gauge IV catheter to drain most of my suprachoroidal or subretinal fluid which is present. Okay, the video again got stuck. Hmm? I don't have in this with them. Yeah, yeah. So this is the ordinary 26 gauge IV catheter. Yeah. So this was how it works is, you see this is a patient with a bullous retinal detachment, and there was hardly any space to do a vitrectomy in this patient. So I just take this IV catheter, and a point of the greatest elevation I just insert it. So this is I'm explaining it how to drain the subretinal fluid. Same way you can drain a suprachoroidal fluid. So once you see the tip is inside the subretinal space, you just advance the plastic tubing and withdraw the metallic stellate. And once you do that, you can see that the fluid is coming out of this. And now you can connect this cannula to your extrusion pump, and you can actively control the rate of drainage of the fluid from the subretinal or suprachoroidal space. So you can do it faster if you have to drain a lot of fluid, and you can drain it slower if the space becomes shallow. So this technique has got several surgical advantages. And this was a 56 years female status post-scleral buckling, and he had a recurrent RD with massive choroidals. And so to drain this, we again, because there was a buckle inside there, so it was very difficult to open it and just go inside. And so we used this cannula to reach this area. You see the tip of the cannula now in the suprachoroidal space. And once you see this, you can start draining it. And you see the level of the choroidal detachment slowly coming down. And this blunt tip need not be withdrawn on decrease in fluid, because it is blunt, it is not going to injure your choroid. And you can do it at multiple sites because it's transconjunctival. So you can do a drainage at multiple sites, and you can reach quite posteriorly. You can see the tip of this cannula reaching up to the macula also. So if the pocket is quite posterior, you can drain that also. And you can leave the cannula while you are doing other procedures, like you're doing laser, or so you can just leave the cannula there and let the fluid drain out while you are doing other procedures. So this was another patient with a post-traumatic choroidal detachment and hemorrhage, and you again see there was so less space that you cannot operate. And again, I use this technique. With a fast mode, I just drain the choroidals very quickly. So this was a patient of kissing choroidals, and the one thing that you have to keep in mind is, because there is no space to insert your instruments, you have to make a anterior chamber. You have to place an anterior chamber maintainer so that when you start draining, it does not result in hypotony and resultant hyphema or a vitreous hemorrhage. Again, I'm using this same technique to drain out the choroidal fluid. So this is, I think I have time. So this is a patient of, this is just to show hemorrhagic choroidal detachment being managed. So this was a patient with a post-cataract surgery choroidal detachment, suprachoroidal hemorrhage and vitreous hemorrhage, and retinal detachment. So again, I'm using the controlled cannula drainage technique to drain out this suprachoroidal hemorrhage. And once you have settled the choroid, you proceed ahead with your vitrectomy. You make a retinotomy, because there was so massive subretinal hemorrhage. I plan to have a large retinotomy in this case, but start with the smaller one and drain as much of subretinal hemorrhage through that smaller retinotomy. Because if you make a larger one and try to drain, the blood will come into the vitreous cavity and obscure your vision. So make a small retinotomy and remove the subretinal blood, and then you can increase your retinotomy, and then now this patient is converted into a giant retinal tear, and you can manage it accordingly. So this is again nano-ophthalmos. You have to do partial thickness sclerotomies to manage choroidal detachment or retinal detachment, which has happened secondary to nano-ophthalmos. And this, sorry. So this is the way you do it as we used to do earlier when we used to do implants, scleral implants for retinal detachment. You make these partial thickness flaps and then you excise those flaps. You can do it in all the quadrants depending upon how much you want to. I prefer to, once I start doing it, I prefer to do this sclerotomy in all the quadrants. Sclerectomy. So this sclera is removed and these patients generally, they have very thick sclera. So it's important to remove as much of the tissue as you can. So complete in all the quadrants. And then this is 3 months post-operative. The retina has settled and the choroidals have settled. And you can compare the pre-operative and the post-operative picture, and the patient's vision improved to 6/18. And now this is my last video. Again, this patient, you can't drain from outside. This is, again, I borrowed from Dr. Manisha. You can make this choroidotomy from internally, and then you can drain the fluid from this choroidotomy that you have made, and you can settle the retina from internally, and then you laser this choroidotomy and you can get a good result. Thank you.
Thank you, Dr. Sangeet, for those interesting videos. I think, Dr. Oni, you have any question? Yeah, please.
Or any trick to prevent that and to know if you have to move
If it is
forward?
the retina is interiorly placed.
Because of the choroidals, the anterior retina is also interiorly pulled up. And a lot of times we create break at the entry.
Break at the end.
It's easily managed, but if we can, any tips to avoid that?
I think if you know that the retina is very, or the choroidals are very bullous and the retina is coming up, you can always drain the choroidals first before making a final entry into the vitreous cavity. I think that will help. I think Dr. Mahesh.
Yeah, I would probably reattach the choroidal detachment before we go inside. So my technique is slightly different. You can use the trocar canal system, but just go inside up to the broadest part of the trocar goes inside and twist it so that it keeps the sclerotomy open, and then inject with the other hand into the anterior chamber or into the vitreous cavity. That itself will allow the serous choroidal detachment to come out through the sclerotomy site. And once the fluid stops coming, then I go inside completely. And any doubtful case, I would probably use a 6mm cannula. You can use a 6mm cannula in a phakic patient also, provided we keep it in our mind that we are using a 6mm cannula. And doesn't mean that all the time it will touch the lens. We can manage that way.
Yeah. So the idea is to drain the choroidals first, let the thing settle down, and then enter the.
Dr. Sangeet, in one of your videos, we saw that you've used a 27-gauge system. Any problems you face when you are dealing with an RDCD with a 27-gauge?
Not really, as such, nothing as such. The only problem is that these are valved cannulas. So if you want to drain it through these cannulas, it won't be possible.
Right. So thank you so much. And we'll move on to the next talk by Dr. Mahesh P. Shanmugam. Dr. Mahesh is the head of Vitreoretina and Ocular Oncology, Shankaraya Hospital, Bangalore, and he's also the current scientific chair of VRSI. And sir would be speaking to us on dealing with tractional hypotony.
And thank you, Dr. Manisha, and it's a pleasure seeing you all this morning. So let's look at how do we manage tractional hypotony. So tractional hypotony happens because of anterior hyaloid proliferation, and we need to make a distinction between anterior hyaloid fibrous proliferation and anterior hyaloid fibrovascular proliferation. Anterior hyaloid fibrous proliferation happens post-trauma. It is not vascularized much, or if it's vascularized also, it's not too much of an issue. And post-retinal detachment surgery, particularly myopes, will have this thick tissue growing in the vitreous base region and extending onto the pars plana and exerting pull on the ciliary body. I have seen that like this post-RD surgery in myopes, it tends to happen. And if you place an encircling band and do 360-degree dense laser, somehow it cuts off the blood supply either to the retina or to the anterior choroid, and that seems to incite this fibrous tissue proliferation. And these people tend to have chronic hypotony, in myopes particularly. Anterior hyaloid fibrovascular proliferation was what happens when we do a vitrectomy for a proliferative disease like a diabetic disease or a CRVO, and then they have this sclerotomy site proliferation which grows 360 degrees along the vitreous base and which is vascularized, and they tend to be a cause for recurrent vitreous hemorrhage in these patients. So the early signs are there is usually an episcleral or conjunctival congestion at the site of the sclerotomies, and you will have this dilated choroidal vessel, dilated episcleral vessels which are dipping into the sclerotomy, and that's a sign that like these patients are developing a sclerotomy site proliferation. And as I mentioned, proliferative disease, they may have recurrent vitreous hemorrhage, and they may develop an unexplained rubeosis iridis, and in the initial stages, they may have increased intraocular pressure and subsequently go on to develop hypotony. And in a phakic patient, they may develop unexplained posterior synechia, and slowly they start developing iris retraction, and then hypotony happens along with iris retraction. So the issues are, do we intervene, and when do we intervene? And persistent hypotony, of course, results in phthisis. In a gas-filled eye, when these start developing this anterior hyaloid fibrovascular proliferation or fibrous proliferation, they tend to progress very, very rapidly, and the retinal detachment becomes very complex, closed funnel very soon. In an oil-filled eye, because of the oil, it masks the changes. So you're not able to make out that this anterior hyaloid proliferation is happening. So a late intervention, it can become irreversible because the longer the ciliary body has been pulled because of the fibrous tissue, the atrophic changes happen in the ciliary body and they don't recover. And if there is a visible retrolental membrane, a vascularized or non-vascularized membrane, which is bridging from one side of the ciliary body to the other side behind the lens, and along with that, there is a long-standing hypotony, these eyes don't do well, and it might as well probably leave it, or try to make an opening in the membrane so that the patient continues to see with the oil inside the eye. But like doing surgery in these eyes is very difficult because the ciliary body and the fibrous tissue is pulled forward, and placing the sclerotomy and going inside causes the retinal detachment again. So let's see some of the examples. So this is a patient with phakic anterior hyaloid fibrous tissue proliferation post-trauma. Post-trauma eyes are reasonably okay to manage because the site of the globe rupture or the perforation is where the fibrous tissue proliferates, and that's the only thing which would have to be dissected. So we dissect it and then segment it away from the rest of the vitreous base and isolate that tissue, then it doesn't tend to proliferate and remains in that area. So in a younger patient such as this, where the lens is not too thick and it's clear, with the proper depression, we should be able to reach up to the anterior part of the vitreous space and the ciliary body and dissect the anterior hyaloid. So this is another patient with a post-traumatic localized proliferation. So here we are dissecting this fibrous tissue which is grown at the side of the perforation or the trauma, has grown at the vitreous base, then extending on to the pora serrata, then the vitreous, then the ciliary body, and it can extend almost up to the iris as well. So there's a localized area of fibrous tissue which is being dissected. These patients may not present with hypotony, but leaving it alone, what happens? This fibrous tissue grows 360 degrees and causes traction of the ciliary body. So these are simpler ones where we will be able to salvage the size and the intraocular pressure can come back. So and usually the retina is pulled up as well, so we may have to do a relaxing retinectomy there and reattach the retina. There is a much more complex fibrous tissue proliferation. The wound is at the site of the limbus. So you can see this thick fibrous tissue growing posteriorly and exerting traction. And we will see that there is a traction retinal detachment. You can see that there is a traction regmental retinal detachment with radial folds. You can see that radial fold extending to the site of the proliferation. So here all the preretinal membranes would have to be removed, then cut the retina and relax the retina, and then try to limit the site of the area of the scar and delimiting it from the rest of the vitreous base so that it doesn't progress 360 degrees. So here, as I was dissecting, found that there was a foreign body which was sitting there within this scar tissue, which was removed. And we isolate this scar tissue from the retina, the anteriorly, the ciliary body and the iris if it is possible, but from the rest of the vitreous base. So these eyes with the localized fibrous tissue, the anterior proliferation tend to do well and they don't go in for a hypotony as well. So that's the reattachment to the retina with oil. So here we will find that this fibrous tissue grows from the vitreous base across the ciliary body and onto the iris. And we will see that the ciliary processes are all gathered together. So we'd have to use a combination of the forceps as well as the cutter to separate this fibrous tissue from the ciliary process and relax the ciliary processes so that they are able to function. So that's what we are doing. So this has to be a careful maneuver because we may be cutting into the ciliary process as well. And this fibrous tissue again grows anteriorly to the iris and starts retracting the iris. So we dissect between the iris and the ciliary processes and remove this membrane. You can see that the inferior PI is blocked because of this fibrous tissue. So release this fibrous tissue from the adhesion to the iris as well as from the ciliary body and dissect it. This sometimes can be very nastily difficult because it can bleed because we're cutting into the ciliary process, or we may be cutting into the iris as well. But with careful dissection, we'll be able to relieve this circumferential traction and get the ciliary body to function again. So here we find that the anterior hyaloid is very thick, and particularly if you have left behind a capsular rim, that also becomes part of this anterior hyaloid fibroscale proliferation. This is so thick that the cutter cannot cut. So it's dissecting it bimanually from the ciliary body and releasing it. And we have to do a limbal incision to remove this fibrous tissue. Fortunately, this patient, as you can see, the iris is not retracted. So possible that patient may recover if the ciliary body is not gone into atrophy already. Then again, most of these eyes will need a 360-degree retinectomy, which is reattached. But the fibrovascular proliferation associated with proliferative disease is different. So here we have a patient with a combined retinal detachment who was operated, the retina was reattached, but then started developing this reproliferation of tissue. Here, the posterior reproliferation is being dissected out. And these are the eyes which will progress very rapidly. And if a patient comes with a recurrent vitreous hemorrhage about 6 months down the line, post-vitrectomy, we should suspect that there may have anterior fibroscale proliferation and intervene rather than wait and watch, because these eyes can progress very, very rapidly into very severe anterior proliferation. So everything is going on well as far as the posterior part of the tissue is concerned. We are able to remove all this posterior part of the tissue. But we come anteriorly, you can see this thick, broad band. So this band of tissue is the one, the whole vitreous base is converted into a thick, broad band of tissue. And this can't be removed because it is so stuck to the ciliary, the underlying choroid. If we try dissecting it, it bleeds so badly. So these eyes would have to be left like this and hope that they don't go in for iris retraction and oil into the antechamber. The difficulties in dissection are, as I mentioned, when we dissect so anteriorly, we are depressing on one side. A little slip in the depression can have a cutter cutting into the ciliary process, and a massive bleeding can happen like this. So you can see the massive bleeding. We may cut into the ciliary body or the ciliary process, and you can see the blood is stuck under the retina where we have done the retinectomy. So this is our issue. If in case there is severe anterior proliferation, you can have iris retraction and silicon oil keratopathy. So if it's a localized proliferation, as I mentioned, if it is traumatic, we can think of doing a pupilloplasty and narrow down the pupil so that the oil doesn't come into the anterior chamber. This can be done easily. As you can see, inferiorly is where the iris is retracted. So we can try to make the pupil round by doing pupil small by doing a pupilloplasty. This is a standard 4-throw pupilloplasty and can in fact create an inferior PI as well as a small pupil. This may not be possible in all the situations, but in limited anterior proliferation, we can do this. But in case there is, you can see the completely iris is retracted, you can do the oil retaining sutures. It's like pretty much a modification of how you do a scleral fixated intraocular lens. I put a square and Deviant's put a star. It depends on how you want it. So this is the same standard 10-0 proline which we use for the SFIOL. So you can create this square so that the oil tends to remain posterior, and we usually put a 5000 centistoke oil because oil cannot be removed in these patients. So to summarize, anterior proliferation is serious, often irreversible, post-trauma, probably salvageable because it can maybe a localized area of anterior proliferation resulting in hypotony. Post-retinal detachment, possibly salvageable. Post-PDR, most often lost because of the very thick fibrous tissue which forms anteriorly. Anatomical success is possible if there is anatomical success in the sense we may be able to attach the retina, but then we may not be able to salvage vision in this eyes because of the hypotony in the oil coming into the antechamber and silicon oil keratopathy. Iris retraction results in keratopathy. So there are some of the broad guidelines. If iris is not retracted and the IOP is around 6 to 8 millimeters of mercury, it may recover, and these are the patients where we treat them with subtenon steroid and topical steroid. Localized iris retraction IOP is normal or high and younger prolif in the sense early in the disease, so that it's not caused ciliary body atrophy and just about pulling on the ciliary processes, we may be able to recover the ciliary body if we relieve this traction. So this is where we do a surgical dissection and pupilloplasty. And if the deep anterior chamber, because the iris is being retracted posteriorly and early iris retraction, and the pupil is blocked on oil in the anterior chamber, we can attempt surgical dissection with steroid, and then we hope and pray that things will work. Iris retracted oil in the anterior chamber, all we can do is to try keeping the oil from the endothelium by doing oil retaining sutures. Thank you very much.
Thank you so much, sir. And I think majority of the cases that you showed were all desperate cases. I just had a quick question. Any question from the audience? Just a quick question, that when would you not attempt dissecting out those membranes where you feel that after this much of time has passed, probably now the ciliary body is not going to take up its function because of the traction?
As I mentioned, if there's a complete membrane behind the lens extending from one side to another and long-standing, in the sense like more than 6 months, then I would probably not. I'll try to create an opening in the posterior part of the thing and leaving it behind. And that other patient where I showed a proliferative disease. So I go inside and find this thick band of the whole vitreous base is converted into a fibrous tissue, all 360 degrees. That again, I will probably not attempt dissecting, because attempting dissection in this is very difficult because you'll be cutting into the choroid, it'll bleed, and the ciliary body, which is already damaged, will maybe make it worse.
So moving on to the next talk, I invite Dr. Vishali Gupta, and she is the head of Vitreoretina and Uvea Services at PGI Chandigarh. She is also the current president of International Uveitis Study Group, and ma'am would be speaking to us on atrophic hypotony secondary to chronic uveitis.
Thank you very much, Manisha, for taking up this very challenging topic of hypotony. So when we come to hypotony secondary to uveitis, please de-learn whatever you have learned so far in terms of the interventions that you would do, because they do not truly apply to uveitis. They are great for trauma and other causes, but please don't try to do all those beautiful videos in your uveitic patients. So this has already been said. It could be just a numerical hypotony, which is just a number, or it could be structural, which means that your hypotony is now started affecting the structures of the eye. The most important investigation when you are looking for hypotony is to assess the ciliary body, and UBM is the way to go, because you really want to assess the health of what is going on in those ciliary processes. So Manisha told me today to speak on hypotony, which is secondary to atrophy of ciliary body. So let's see what happens. On the left, you would see a kind of a flow diagram, which chronic uveitis causes atrophy. Atrophy causes shutdown. Shutdown causes damage to the ciliary epithelium, which kind of increases the aqueous outflow due to the traction, and that results in the hypotony and further atrophy. So while we are all busy looking at preventing the scleral outflow, decreasing it, pulling out anything which is grown on the ciliary body, I think what needs to pay attention in the uveitis is don't allow the uveitis to become chronic and your problem will be solved. Honestly, in the last 15 years, I don't remember seeing any patient of hypotony due to uveitis which is being managed in our center. And I'm just not boasting about it. What I'm saying is, with all the biologics and the armamentarium in your kitty you have today, if you develop hypotony in uveitis, it's a serious, serious failure as a treatment physician to us. These are the kinds of JIA patients we used to see a decade ago. We don't see them anymore with the fortunate enough to have good medications. So childhood uveitis was honestly one of the commonest causes of chronic hypotony, and the children will present like this, and do the UVM, you will find the ciliary body is totally knocked off, the other eye, peripheral anterior synechiae, and it was not really a pleasant scene. We do get them once in a while referred from outside now, but that is because there has been delay in the management. Now, suppose you have ended up in a patient which has resulted in hypotony. The question would be, how would you manage? So one, I have already highlighted this, that this should not happen, but suppose it has already set in and now you have to manage, what should you do? Steroids would hold an important part in managing the hypotony, which has already come up, and there are intravitreal implants. Unfortunately, this fluocinolone is not available to us, but literature has shown that you inject it into a hypotenuse eye, it does help. Intravitreal triamcinolone is something which is easily available to us, and Jonas et al. Did present a series of 3 patients, because it's a rare thing, with chronic long-standing hypotony, where they inject intravitreal triamcinolone for successfully increasing the IOP. The injections need to be multiple over a period of time, and they have to be combined along with the anti-inflammatory therapy to prevent further damage. It is not a standalone treatment that you keep on treating them locally. Now, some of these patients in the past, and if there are some date, they all are dated back to 2004s and 3s, and honestly, I could not pick out any patient recently whom we had to, treat for hypotony. So this IOP6, both eyes, posterior segment looks back. So we used to do parsplanal lensectomy, vitrectomy, and multiple posterior subtenon Kennicott. I personally would not inject intravitreal because that causes a lot of disturbances in the vitreous and makes monitoring difficult. So as was mentioned by Divyansh and I think Dr. Mahesh, PST Kennicotts are fine, but be very careful in injecting in a hypotenuse eye. You don't want to end up with another complication. You can keep on supplementing it for years together because that's the only thing that keeps them going. DEX implants, very useful, but DEX implants are only if your patient is phakic. Majority of these patients, you would have removed the lens. And if it is parsplanal lensectomy, vitrectomy that has been done, DEX implants tend to migrate anterior and kill the endothelium. So make sure that you are not injecting Ozurdex implant if the patient does not have a very intact posterior capsule. There are desperate situations, like if we see at the right eye of this child, cornea was affected as well. So these are kind of very desperate situations where you would think of doing keratoprosthesis, vitrectomy, silicone oil placement, and the implant, but very, very dismal prognosis. This is the drug probably Dr. Mahesh was discussing about, is the ibupamine. Ibupamine kind of reduces the hypotony by increasing the pressure, but unfortunately it's not available to us, so I will not spend time. There is a report of paradoxical action of latanoprost that normally when administered at a higher doses leads to rise in IOP because it causes the inflammation in the trabecular meshwork, and there is a case tried in chronic Behçet's, but honestly, I will not do it to my patients. Viscoelastics, yes, those desperate situations, there are reports you can inject viscoelastic in the eye, and there is a report from our group also that we do vitrectomy with silicone oil tamponade. Will I do it today? No, because putting anything in the eye in patients with uveitis, whether it is silicone oil, whether it is sutures, whether it is repairing, whether it is IOL, in the long run, it's not good. We, from our center, published a report that we do IOL implant in JIA patient with Ozodix implant because we thought we were so smart that we were able to control the inflammation in the short term, and we published it also. And when I see those patients, and we will be coming out with our series 20-year follow-up, I'm old, 20-year follow-up on those children, majority of those eyes are having complications of IOL and not of the inflammation. So do very minimalistic things in uveitic eye. Don't get carried away in doing surgical interventions in these eyes. So I think I'm kind of running out of my time probably. So I'm just going to give this brief algorithm. So this is the situation that will come across many of the times, that you have a complicated cataract and there is a hypotony in a uveitic eye. Now first make sure the eye is quiet. The very fact there is cataract does not mean the posterior segment or the vitreous is absolutely quiet. It's just you can't see. And there is hypotony, see whether it is acute or chronic. If it's an acute hypotony, it's not a problem at all. Just use whatever you have in your armamentarium to control the inflammation. If it is a chronic hypotony, that's what we are discussing here. If it is chronic, if it is acute, I already mentioned, control the inflammation, control the ciliocoroidal detachment, not by putting buckles, but by controlling the effusion. If it is chronic, it could be a cyclitic membrane, which could be a problem. It could be atrophy. Membrane, Dr. Mahesh has discussed with you already. It could be ciliary body atrophy, or it could be membrane plus atrophy, which is very common. In this scenario, don't make it an ego hassle to pull out the entire membrane from the surface of the ciliary body, because the moment you are pulling that fibrous traction, you are causing more of ciliocoroidal detachment. You are causing more atrophy to whatever the remaining ciliary processes are. So there is no need to, pull it out from the surface. Instead, you can make small nicks. And those radial nicks can be made in between the ciliary processes just to relax it so that it's not going in a zipper-shaped fashion. You are just relaxing it, give a very, very good anti-inflammatory, biologics, immunosuppression, and try to keep. Many of these children will see better with the pressure of 6 and not extensive intervention, rather than having, trying to peel off everything and losing everything in the bargain. So algorithm is this one, and I think my time is up. So surgical solution is only if you have a leak or cleft, which you can dominate. If there is nothing, these are some of the things which can cause. It has all been addressed, but to me, control the inflammation. Thank you very much, Manisha, once again for this great topic. Thank you.
Thank you, Dr. Vishari, for that wonderful talk regarding the differences between the management and uveitis. We're running short of time. We'll take the questions in the end, ma'am. And I'd like to re-invite Dr. Manisha, who is going to read the paper for the Narasimha Rao Award, correlating VEGF levels with prompt clinical regression of tubercular granulomas. Dr. Manisha.
So good morning again, and I'll just quickly run through this particular presentation of mine since we are short on time. So way back in 2014, we had this young girl who presented with this huge optic nerve head granuloma and a huge granuloma in the macular area. She had a vision of counting finger close to face. She revealed multiple enlarged mediastinal lymph nodes and a patchy infiltration in the left apical region, all suggestive of tuberculosis, with a very high Mantoux test reading. So she was put on ATT and she was also started on IVMP followed by oral steroids. She started responding well, and you see that there was a whole regression of the granuloma both on the optic nerve head and in the macular area. But to our surprise, the inflammation and the granuloma started coming back again, and we were totally lost what we were dealing with, and we assumed it to be a paradoxical worsening, and we increased the dose of the steroids. But finally, this patient, the eye became a painful blind eye with extensive neovascularization and exudative retinal detachment. And out of desperation, we started treating her with anti-VEGF injection. We started her on second-line ATT in the form of ofloxacin. And finally, this eye was lost and we had to enucleate it. And we sent the eye to JB sir at Shankar Nethralaya, Chennai, where he confirmed that very much this patient was suffering indeed from TB granuloma in the eye. Now, the question was that despite having put her on various anti-tubercular treatment and steroids, we lost this eye, and we did publish this case as a rapidly blinding posterior tubercular uveitis. But this started a few questions in our mind that this patient was responding in the chest as confirmed by the physician, but not really responding in the eye, and why was that happening? Was the delivery of the ATT drugs not adequate inside the eye? Why did she develop a painful blind eye with neovascularization, which was so acute in onset? So was it a high VEGF drive? And could we have done really something else other than just putting this patient on ATT and steroids? And that is where this entire study came up from, where we correlated the intraocular VEGF levels with prompt clinical regression of TB granulomas treated with anti-VEGFs and moxifloxacin. Now, we know that TB granuloma is the most well-recognized phenotype of intraocular tuberculosis, and we also know that these are hypoxic granulomas which are having a very high VEGF drive. And there have been reports by the PGI group that these patients develop very fast RAP lesions, which are seen as typical hemorrhages over the TB granulomas, which has now become like a distinct sign for recognizing TB granulomas. So in our study, we evaluated the intraocular VEGF-A levels and correlated it with the regression of the TB granulomas, and also we evaluated that what was the visual improvement in these patients. So 10 consecutive patients with TB granulomas were included in the study. Aqueous samples were collected at the time of giving the injection and which were subjected to ELISA test for evaluating the VEGF-A levels. We gave intravitreal bevacizumab, that's Avastin injections, along with moxifloxacin, which was given every week till the granuloma showed a regression, along with ATT and steroids, which were not stopped. And we correlated the VEGF-A levels with the clinical regression of the granulomas. So the mean age was around 25, and 8 patients had choroidal granuloma and 2 patients had presented with optic nerve head granuloma. The mean follow-up was around 1 year, and these are the details of the VEGF-A levels, which were measured after every subsequent injection that we gave in these 10 patients. And this is how the clinical regression is. The details are all outlined. So the mean baseline VEGF-A levels was measured to be about 1000 picograms per ml in these patients, and the mean VEGF-A level at the time of last injection had dropped down to around 27. A prompt clinical regression was found in all the 10 patients within 4 weeks of starting these intravitreal injections, and the average number of injections required were around 3. 4 patients had recovered a vision of 6.6, 2 patients had a vision of 6.18, and 4 patients had recovered a vision of less than 6 by 24. And this was probably because these patients had a regression of the granuloma with much lesser scarring that was seen with just a systemic therapy. So this is one of the patients. You again see a huge granuloma on the optic nerve head and a choroidal granuloma. 2 weeks later, she shows a beautiful regression of the choroidal granuloma, and subsequently she develops a new lesion which is diagnosed as a paradoxical worsening. She's treated with IVMP. You see there is a drastic fall of the VEGF-A levels, and this is the entire timeline of the patient. But what is important is that we are able to recover a vision of 6.6 N6 in this patient at the end of the entire treatment. And this is another patient where you see that the VEGF levels were as high as 1200 and they have dropped down to 257, and the patient has responded very well. Now, what is important for us to realize is that in TB granulomas, granilomas, the VEGF-A levels are as high as 1,000 and more. VEGF levels which have been reported in literature in active pulmonary TB patients is in the range of 700 to 800, and patients with AMD CNVM have the VEGF-A levels in the range of about 100 to 200. So there's a huge difference, and that is why if we were to treat these patients just with a monthly injection, probably it's not really going to bring down these high VEGF levels so fast. So this is just a cartoon depicting a typical TB granuloma where you have caseation necrosis surrounded by, I'll just take 1 minute. Surrounded by the macrophages which are harboring the TB bacilli inside, surrounded by the abnormal vessels. And what is happening in these hypoxic granulomas are that there are high VEGF-A levels which are causing this abnormal vasculature surrounding these granulomas, leading to an unequal distribution of the ATT drugs, reducing it apparently to a monotherapy and thus increasing the risk of multi-drug resistant TB. When we are giving anti-VEGFs, it is decreasing the hypoxia, avoiding the bacilli from becoming dormant, and increasing the bactericidal effect of INH. It's also normalizing the vasculature of the granuloma, thereby increasing the small molecular delivery of ATT and decreasing the risk of multi-drug resistant TB. Moxifloxacin is basically like a second-line ATT drug which we are using, but it's important to give ATT in these patients because it's only pyrazinamide which is going to be getting an access into the central caseation necrosis. So VEGF levels are measured for the first time in this particular study, and an effort was done to normalize the vasculature of the TB granulomas as quickly as possible so that the ATT drugs which are given systemically are having a much better reach inside the TB granulomas inside the eye. This was just a proof of concept study and hence a small number. And now we are very much in the process of doing a randomized study where we have already enrolled around 20 patients, and we are going to be soon coming out with the results. So we just have to keep in mind that TB granulomas are hypoxic granulomas driven by very high VEGF-A levels, and just giving ATT and steroids may not really be sufficient to regress these granulomas. So thank you once again for your patient listening.
Thank you, Dr. Manisha, for that. That was a very innovative proof of concept. I think we're running short of time and we have to close. So I'd like to thank all the delegates for their attention and for attending this IC. Thank you.
Thank you, everyone. Yeah, can we just have a quick photograph?